Hello, good morning, everyone. We have here a great pleasure to introduce Dr. David Rubin, is the most knowledgeable doctors on the subject. I could be here for hours talking about his curriculum, but I just say that Dr. David Rubin is the Joseph Kisner Professor of Medicine, Chief of the Section of Gastroenterology, Hepatology and Nutrition, and the co-director of the Digestive Disease Center at the University of Chicago Medicine. He published hundreds of papers in the most prestigious medical journals, and on top of that, he's such a good and kind person. He presented us with a conference about the role of the endoscopy in detecting dysplasia in cancer, colorectal cancer, and the best way to do it. Thank you, Dr. Rubin.
Tomorrow. So when I finish my lectures with you, I have to clean the house and make food for tomorrow. So I'm happy to do this first, and then I have real work to do. We're going to talk about dysplasia and cancer prevention in inflammatory bowel disease, which is the area that I started my career in and which I still have great interest. I have a number of important disclosures, but I want to be clear that this presentation is my own, and actually, arguably, I don't think any of these consultancies affect what I'm saying today, and I take full responsibility. All right. The challenges of cancer prevention in IBD are many. We have problems that we have to solve. The first one is that although many studies have now shown that we understand the risks of dysplasia and cancer, it's still a rare event. And because it's a rare event, it's hard to study, and it's hard to know whether what we're doing is making a big difference. However, I'm going to tell you that I think it is. Colonoscopic screening and then subsequent surveillance has not been shown to have a mortality benefit. So when I give talks like this to cancer specialists, they are not that impressed with what we do. On the other hand, thankfully, there isn't a high mortality that we need to demonstrate mortality benefit from, and that's a good thing. Our technology continues to advance. We're getting better at what we can see and what we can do. And therefore, it's also a challenge that we have to interpret how to use technology better and keep the guidelines moving forward. You heard a beautiful lecture from my friend Bo Shen about using technology in new ways in IBD. And I think the same is true in thinking about surveillance for dysplasia and cancer. Patients don't want surgery. They're very hesitant about surgery, and probably rightfully so, but it's obviously and very importantly needed in this situation for some of them. And lastly, we know surgery takes care of the colitis and the cancer risk primarily, but it's not perfect, and we know that too. So there's many challenges to thinking about this, and I would argue there are many more challenges to doing research in this field. So I'm going to do my best to summarize the updated research and to give you clinical pearls in the management. This is a slide I created years ago, which I think is very relevant to thinking about cancer risk in patients with inflammatory bowel disease, and specifically inflammation of the colon. There's a timeline from birth to death across the x-axis here from left to right. And you can see that the at-risk patient is the patient who develops chronic inflammation. In this model, we believe that dysplasia occurs before invasive cancer, but we have learned that it may not always be directly and similar to the non-colitis patients where they have a polyp and it takes time to become an invasive cancer. So part of the challenge is that. There's also defined on this cartoon what we call the detectable preclinical phase. The detectable preclinical phase is the time during which we can pick up dysplasia or early stage cancer before the patient has symptoms, gets sick, or obviously dies. So obviously a very important one. The next part of this, though, is what we're currently doing, which is scheduled colonoscopies with targeted and sometimes non-targeted, or what you call random biopsies. And if we do the colonoscopy and biopsies when the patient doesn't have dysplasia, we don't pick up anything, but if it's during the detectable preclinical phase, we find it. And then, of course, once we find it, the general strategy has been that we would recommend surgery. At least that was the traditional approach, with the idea of secondary prevention of the cancer and death. What has changed in the field has been a couple of important points. Number one is that the detectable preclinical phase might be getting bigger. And if we can detect things earlier, it implies that we might not be able to see everything as much as we want, but it also implies we might not need surgery as often as we once thought. The other part is that we've learned about primary prevention. Now, in the early days, we talked about chemo prevention with aminosalicylates, for example. But primary prevention can also mean controlling the inflammation and therefore preventing dysplasia altogether. And that's a very interesting concept, and I'll show you some evidence that suggests that might be true. So this is the model in which we think about cancer prevention in inflammatory bowel disease. And you can understand how we can shift or change the intervals and the interventions in meaningful ways to develop a plan to prevent cancer in our patients. So our evolving approach to cancer prevention in IBD is still secondary prevention. It still relies on colonoscopies and identifying lesions, either those that we can see or those that we can't see. The use of augmented imaging techniques like high definition scopes and electronic or dye spray chromoendoscopy is becoming much more widespread, and I bet many of you already have those equipment. We are relying on being able to see dysplasia much more than we thought in the past. We have recommended and we recognize it's possible to remove endoscopically discrete lesions that you can see and remove completely. The concept of active surveillance after dysplasia has been found and removed. Surgery when unresectable neoplasia, recurrent neoplasia, or the cumulative risks are unacceptable, and I'll summarize what those are in a few minutes. And importantly, segmental resection is possible. So we've been moving from our older approach, which was that the organ was at risk and we should sample the mucosa by doing random biopsies in a segmental fashion, to much more active approaches to seeing dysplasia, understanding better what the natural history might be, and the movement away from surgery, or at least from total proctocolectomy, to considering active surveillance or segmental resections. So that's how the field has moved. Now we'll discuss, and I'm sure in the cases we can debate whether that's right for everybody. So how big is the problem? Well, we certainly continue to acknowledge that patients with chronic inflammation of their colon have an increased risk of colorectal cancer. The risk varies, but it's about twofold greater than age-matched controls. And certainly in younger patients, this becomes a bigger problem because we otherwise wouldn't be looking at them. In addition, we've learned that the longer you have the disease, the greater the risk. That's not new, but what may be new is the incorporation of cumulative inflammation and how to incorporate that into that time. And I'll tell you about that in a moment. And we certainly recognize that the greater the extent of disease, the greater the risk of cancer. Although, to be very honest with you, we don't know why that's true. Why is it true that somebody with 20 years of pancolitis has an increased risk of colorectal cancer, but somebody with 20 years of proctitis doesn't, or at least doesn't statistically have that risk? We don't understand that. Is this an organ-specific cumulative inflammation and a stem cell-driven mutation accumulation, or is this just due to cumulative inflammation that's worse when people have a larger amount of their bowel involved? It's a very fundamental question, and it's a known risk factor, but it's never been fully explained. It's an interesting one. Now, it's also important to acknowledge that it appears that the rate of cancers in IBD have been decreasing. And this is a good thing, and this is what I tell patients, because when patients with ulcerative colitis are diagnosed, they go to the internet and they right away read that they're going to have cancer. Not that they might get cancer. It literally says on many websites, you're going to have colon cancer. And remember that historically, they used to recommend patients just go and have their colons removed after 20 years of disease. They didn't wait for anything because they couldn't find it and they didn't know what to do. That's changed, but you can see that even in these population-based data sets from Sweden, Olmsted County, Denmark, you can appreciate that the rates appear to be declining in both ulcerative colitis and probably in Crohn's of the colon as well. In the St. Mark's surveillance database, which is the largest and longest surveillance database in the world, which is in the United Kingdom, you can see that not only have the incidence rates appeared to go down over the years, but when cancers are found, they're being found at earlier stages. And being found at earlier stages, of course, means that they can be cured and those patients do better. So we have evidence that's indirect that something we're doing is working, or it may be because of some other reason. Maybe our secondary prevention is actually doing its job. We're finding dysplasia in cancers and we're sending patients to surgery. So they're coming out of the data set and therefore they do well. It may be that our control of inflammation is better and that we're reducing risk because we're controlling the disease more effectively. The third possibility is that as ulcerative colitis has gone up in populations, the type of ulcerative colitis that has emerged in recent decades is a different type of ulcerative colitis than the classic ulcerative colitis in which cancer was described. I think that's less likely. And I'll tell you that in places in Asia that have seen a rise of colitis that is very rapid, they're now seeing cancers as well, and I'm sure you are, and therefore that seems less likely. So the message is currently to manage the disease and perform surveillance as effectively as possible. And that's what I was invited to talk about. What's the most effective way to do surveillance? So let's think about this. The first thing is to know what the risks are, right? And I divide the risks into those that are potentially modifiable and those that are not, what I say is immutable. So inflammation, backwash ileitis, which may be a marker of more extensive colonic inflammation, the presence of pseudopolyps, which I believe personally is a marker of previous severe inflammation. So it's an indirect biomarker. Prior dysplasia. So since we don't send everybody to surgery anymore, remember that someone who's had dysplasia before is likely to get it again. And having a mass or a stricture, of course, is a big risk factor. The things that are immutable are being a man. They seem to be higher risk, and it probably is better to say male sex, but I put male gender because most of the studies are self-reported and they're variable the way they write the papers. Longer duration of disease, I already told you, the greater extent of colonic involvement. Remember, a family history of colon cancer can be on top of the colitis, even if it's not a family history of IBD. Having PSC is a very important risk factor, which I'll talk more about, and having a younger age of diagnosis independent of disease duration. So you have to think about what are the individual risk factors for the patient in front of me when you make decisions. Now, what we've been learning as well, just like in the general population, younger age colon cancer is occurring more often. We've also learned that this may be true in the IBD population. And now there have been a number of studies that suggest that if we start screening at 10 years, which is where people had suggested we do it, we may be missing as much as 6% of cancers. So we want to start a little earlier. In the American College of Gastroenterology ulcerative colitis guidelines that I co-authored, we pushed it back to 8 years. So it doesn't say start 8 to 10 years after diagnosis or after symptoms. It now says start at 8 years, and we believe that's right. We also have learned from multiple studies, and unfortunately, this could be a longer table than what you see here, but these are 3 of the studies, that the degree of histological inflammation is associated with the risk of colorectal neoplasia. Histology. So this is important because we talk about whether we should be treating colitis to histological control, And we haven't quite gotten there on the treatment front. It's an interesting question, but we do know that the more inflammation you have, if you look at biopsies over time in patients, the higher the rate of subsequent cancers. If you look at our study at the bottom, which is the third one there, you can appreciate that the odds ratios for subsequent cancer were threefold greater in general with patients who had cumulative inflammation. And we did it by categorical scoring. Now, how do you incorporate that into clinical practice? Well, if you have a patient who on their last colonoscopy was inflamed, you should know that they're already in a category where that risk is twice as high as if they were not. If they have that over time, the question then becomes, what is the overall risk the longer they have it? And I'll show you that in a minute. So this is on the left, a very nice study, again from St. Mark's in the UK, where they created essentially an arithmetic formula where they add up the amount of inflammation over the number of colonoscopies and years the patients had disease. And based on the formula, they were able to show that it wasn't just how much inflammation was on a single exam or two. It was the cumulative inflammation that they called an inflammatory burden that increased the risk of neoplasia. On the right is a subset from the study I just showed you from the University of Chicago, from my lab, where we validated their score. Now, how do you interpret that for your practice? Well, there's a few things. The implications of understanding cumulative inflammation and colorectal neoplasia in colitis are, number one, the acknowledgement that patients who are walking around living with active inflammation have an increased risk than those who are in remission, regardless of disease duration. Number two, that control of the disease over time is really important. So the message to patients is we want you to be in deep remission and we want it to last. Number three, it suggests that the risk is not set after a single episode of severe inflammation, that in fact, you can modify the risk if you had severe inflammation, maybe you were hospitalized for bad ulcerative colitis, but now you're in remission for years, that might in fact reduce your risk. And we have a paper that just got accepted that showed that if we get the histology all the way back to normal, the risk of dysplasia is even lower, which makes sense, but it hadn't been shown before. And therefore, it supports the general strategy that we should try to treat to endoscopic improvement at least, and maybe even histologic control. It's a very important message, and this is a relatively new concept as this has evolved. Now, in PSC, of course, we recognize that patients with PSC have a higher risk than others. We don't know why. There are many theories that maybe it's some kind of carcinogenic bile acids. Maybe it's because they've had more inflammation than we realized because they have relatively less severe colitis. But the bottom line is we know that patients with PSC have a higher rate of cancer. And what we showed a couple years ago now in the CGH journal was that patients with PSC had more histologic inflammation in their proximal colon than in the distal colon. And by the way, patients with PSC have a higher rate of dysplasia and cancer in the proximal colon than in the distal colon. So this is a very important message. Number one, it explains a bit more why patients with PSC may not have active colitis symptoms. Their inflammation is in the part of the colon where they won't feel it as much. Number two, it reminds us that we really do need to be looking annually in these patients, not just for dysplasia, but because we can't rely on what's going on with their disease activity based only on how they're feeling. Maybe a calprotectin is helpful in that setting, but we need to look for dysplasia. And number three, the fact that there's increased histologic inflammation in the proximal colon suggests that's why patients have dysplasia and cancer more often in the proximal colon with PSC. So this, I believe, it was in CGH, but I think this is a very important paper. Obviously, I'm biased because it came from my fellow in my group, but we're very excited about this and we think it's an important finding. Now, subsequently, people have also said, well, how often do we need to do surveillance? if a patient has prior dysplasia. And what this nice study, which was from a combination of European and American collaborators, demonstrated was that if you have two negative exams, good exams with no dysplasia, the subsequent risk is very low, and you can start to separate out the intervals again. So how do I choose intervals for follow-up? Well, if it's PSC, it's always annual. If it's somebody who's had prior dysplasia, I do more frequent exams, one at 6 months, and then I'll do another one 6 months after that, 2 short interval exams. And if they're negative subsequently, I will let them start separating out. I don't go all the way to 5 years, which is what the British Society guidelines would suggest in somebody with no dysplasia. The most I'll let my patients go who are doing well would be 3 years. So how do we detect our lesions? Well, one of the most important papers that tried to summarize our current approach, and now is becoming somewhat dated, was this consensus statement paper called scenic. Now, often it's misquoted as a guideline. It's not a guideline, it was a consensus statement of experts. And I was part of the group, and I'm proud of what the group did, but I want to make sure you understand that this was the best expert recommendations, not guidelines. So number one, they acknowledged that high-def scopes are better than standard-def scopes. Narrowband imaging was not better than white light at that time, but has subsequently been supported by evidence, especially when you're using high-def scopes. Dye spray chromoscopy was better than white light endoscopy in standard definition scopes. At the time of scenic, it wasn't clear if that was true with high-def scopes. We now know that it probably is not. Newer technologies enable ongoing surveillance instead of sending everyone to surgery. And there's distinction between follow-up of visible and discrete and resectable lesions and those that are found by random or non-targeted biopsies. So that's the summary of scenic. Now, what have we learned? Well, first of all, there was a lot of evidence that fed into scenic. One was most dysplasia is actually visible. So despite the fact that we were all taught when we were in training, and those who are older remember this, we thought dysplasia was invisible, which is why we did random biopsies, and it's why we send people to surgery when we were lucky enough to find it. There was a study at the St. Mark's Hospital. There was a subsequent study here at the University of Chicago, and we learned that most dysplasia is actually visible. So the first thing to remember is we should keep our eyes open and target things that look abnormal. And by the way, this retrospective study that I did when I was a junior faculty member was with standard def scopes. This wasn't even with our high def scopes. Now, subsequently, there have been many studies that have looked at chromoendoscopy using dye spray in standard def and in high def scopes. And of those that are randomized controlled trials, which are on the left side of this slide, you can appreciate that there was not a significant, there was not a large difference between them, but there was some benefit to dye spray over the white light in detecting dysplasia. You can appreciate as well that when you looked at the difference between scopes, it was true in standard def scopes where chromoendoscopy with dye spray was twice as good at detecting dysplasia as white light. But when you used a high definition scope, you lost statistical significance. In the non-randomized controlled trials, these are hard studies to do, so I have all due respect to my colleagues. You have to appreciate that when you were not randomized, you can see that dye spray had substantially increased risk of finding dysplasia compared to white light in both standard def and high def. But you can also appreciate when they're not randomized that the endoscopist may be biased in how they use the technology and how they look for dysplasia. But that might be okay. To be biased looking for dysplasia means you're finding it. I'm just trying to play devil's advocate here. In addition, we have some studies that have been very interesting. This is a very large retrospective study where they found that the use of chromo in surveillance did not increase dysplasia detection over high-def white light. You can see this is the largest study that looked at that, and that's because it was retrospective. The prospective studies are very hard to do. So they concluded that it wasn't necessarily important to do chromo in everybody. I think that that might have been a bit short-sighted, but it was an important study nonetheless. When you're using chromo or high def with narrowband imaging, you want to be able to understand what you're looking for. And I'm sure that this particular audience this morning knows about pit patterns, but it's important to acknowledge that these can be very helpful. It's essentially in vivo pathology if you're doing it right and you know what you're looking for. And the neoplastic and non-neoplastic patterns are well described. And therefore, this is what led to the consensus scenic statement that if you can see it and remove it, you can follow up, as opposed to if you find it accidentally or you can't remove it, you of course need to consider and send them to surgery. So if it's not going to be everybody, who would you do chromo on? And this is what I do in my practice. Certainly patients who have previously confirmed dysplasia or who have multiple risks and who are not going off to surgery. I do chromo in their follow-up. I use selective chromo to define lesions. So if I see something, I may then spray the dye spray, and my preference is methylene blue, on the lesion to clarify better, because I really like how that looks and what that shows me. Obviously, the patient has to have minimal inflammation and a very good to excellent prep. I include PSC here, but I want to tell you there's no study that I know of that shows that chromo is better for patients with PSC compared to white light. They might be just the same as the other colitis patients, and all these other recommendations apply. In addition, there are a couple studies that I'm aware of, including ours, that show that after dysplasia is found either by random biopsy or maybe even visible under white light, subsequent chromo has a benefit. So if you find it in a patient with white light and you're going to do that 6-month follow-up, use chromo then. And in both of these studies, the DPEC study is obviously larger than mine, but in both you see that when you used chromo, you were able to find more lesions, and it did influence practice. And in fact, in my study, we even found 2 cancers when we did chromo in follow-up after dysplasia was seen on white light. So there is some benefit to doing this subsequently. So if you want to think of your regular colonoscopies with high def and maybe narrow band as being your screening, and when you identify dysplasia, you do chromo or you send it to a colleague who can then do chromo, that might be a good use of the technology. So what about narrowband imaging or virtual chromoendoscopy? Is this as good as dye spray? Well, a meta-analysis would suggest that it might be, especially with high definition scopes. You can see here that there's a variety of different virtual chromoendoscopies. There's autofluorescence, there's iScan, there's the Fuji system of intelligent color enhancement, and then there's what I've referred to as narrowband imaging, which is what I use with our Olympus scopes. You can see that in general, it might be just as good as dye spray. And therefore, in my practice, I routinely use narrowband imaging while I'm removing during withdrawal, and I use dye spray only in specific situations otherwise. And I think that there's more technological improvements coming, and if you're comfortable doing it and you know what the pit patterns should look like, you can incorporate that into your practice. What has also been described is an increasing number of patients who have undergone endoscopic submucosal dissection to remove colitis-associated dysplasia. Of course, our colleagues in Japan have done this well. There's also a nice series from Italy, and you can see a couple more recent series that have described this. This is a tough thing to do, and it also has complications that you need to know about. So it's important to be careful and to know who's doing this. In my experience, the only place where I felt this is useful is when it's rectal dysplasia. And then I have my interventional endoscopist help me with that. So when would colectomy be indicated? Well, I think you have to risk stratify the patients and risk stratify based on the dysplasia that's found. For the patient and disease-related factors, I've outlined them all for you, and I've told you men versus women, the degree of inflammation over time, the willingness of the patient to stay actively surveyed versus those who are non-adherent, and then the dysplasia-related factors. The higher the grade of dysplasia, the morphology, whether it's flat or polypoid, whether there's multifocal or unifocal, and whether it's been seen on more than one exam. All of these things get factored into a surgical recommendation. There have been a couple studies now, including one from our center, that show that segmental colectomy may be reasonable. On the left is the study from our group, again, my fellow at the University of Chicago, where we had a number of patients who selectively went for segmental resection. You'll notice that more of them were Crohn's than ulcerative colitis, but it has been done in some patients with ulcerative colitis. And on the right is another study from our colleagues in Europe, where they showed similarly that this can be performed. I have some caveats, though. I don't think this is necessarily the right approach at all for young patients. I think that number one, you need to make sure people are in complete, deep remission. Doing a segmental resection with someone who has dysplasia, but they're actively inflamed, doesn't make sense. Number two, I think it's when they have a single focus of dysplasia as opposed to multifocal dysplasia, which I think is a patient who's going to have problems in the remaining colon. Number three, the patient is willing and able to have ongoing surveillance of their retained colonic and rectal mucosa. And number four, in general, we consider it for people who are older, where having an ileostomy or having a J-pouch is going to be difficult or not even possible. And therefore, we leave the rectum in to maintain continence. Obviously, they can't have rectal dysplasia. So there are some very specific subtypes of patients where segmental resection may be considered. So my last slide is a summary. Here's what I propose as your active surveillance algorithm. You should start with a screening exam at 8 years, except for those with PSC. You need to be thinking carefully about what are my patient's individual risks, including cumulative inflammation over time. If you're using standard definition scopes, the results are in repeatedly. We know dye spray is appropriate and needs to be used to better see what you're looking for. If you're using a high definition scope, there are enough studies now that either electronic or virtual chromo or dye spray are options, and even some data to suggest white light might be okay if it's a clean colon in remission. The role of random biopsies is uncertain, but I do use them when I'm trying to assess an area that's inflamed and I can't see very well, or when I want to just assess how much inflammation there is, which is a separate lecture. When you find dysplasia, if it is endoscopically visible and you can remove it completely, the current data and guidance would suggest that you can perform active surveillance, which means a short interval colonoscopy or two. And if those are negative, you can go back to an interval that you'll decide. If it's flat or found accidentally on random biopsies or is unresectable, you need to then send them for surgical consultation. If it's multifocal or high grade, they need to go to surgery. And I think that this is an appropriate way to consider doing this. The role of endoscopic submucosal dissection has not been fully defined, but if you have a colleague who's able to do so and the rest of the colon is okay, perhaps it's best to consider that in the rectum. And I'd be interested in what my colleagues might say. So with that, I want to thank you very much for the opportunity to update you on cancer prevention and IBD.
Thank you, Dr. Rubin. This great section lecture that tells us an update in this subject. And now we have an opportunity to discuss some cases. We have such a great panel here. Dr. Fábio Teixeira, Master and PhD in Surgery for UNESP, and Director, Coloproctologist and Director of the Clínica Gastro Saúde, Antônio Carlos Moraes, Master in Gastroenterology for the Universidade Federal do Rio de Janeiro, já ia dizer Rio Grande do Sul, Rio de Janeiro, Head National of GastroDoor. It's a great network of hospitals in Brazil, and member of FBG, Federação Brasileira de Gastroenterologia, and our great and loved GDB. Elisa Riocababa, thank you for having here, and medical assistance of endoscopy gastrointestinal in Hospital das Clínicas USP, and other great titles. And I would like to call Alexandre Carlos to present us. Alexandre Carlos is a medical assistant of the Department of Gastroenterologia do Hospital de Clínicas de São Paulo, USP. He will bring us a case for discussion about displasia. Please, Alexandre.
Então, por favor, Alexandre.
Bom dia a todos. É um prazer estar aqui, né? Agradeço o convite junto à SOBED. E é uma grande honra, né, dar uma aula logo após, apresentar um caso logo após dois maiores expoentes americanos em doença inflamatória intestinal, que é o Bolshen e o David Rubin. Então, eu vou apresentar um caso meu real, tá, relacionado à displasia e doença inflamatória. Então, trata-se de um paciente do sexo masculino, 32 anos. Ele tem uma doença de Crohn de longa data, diagnosticado em 2000, de forma pancolite e comportamento inflamatório e perianal. Era um paciente que vinha fazendo uso da azatioprina, 2 mg quilo-peso, e infliximab, desde 2010. Em 2016, ele entrou em remissão clínica e, após 8 anos de doença, ele era candidato a entrar no screening de vigilância para câncer coloretal e foi encaminhado para a realização da colonoscopia de rastreio. Aqui seria a colonoscopia, né? Então, eu retirando o aparelho, você mostra que realmente é uma pancolite quiescente com inúmeros pseudopólipos, mas, ao chegar no reto, nós encontramos algumas alterações, tais como essas duas áreas de lesões plano elevadas, né, de padrão granular, localizadas em reto, né? Como vocês podem ver. Realizamos a cromoscopia, né? Então, aqui à esquerda, a luz branca, e à direita, corada com índigo carmim, em que mostra uma lesão realmente extensa, uma lesão de cerca de 30 milímetros, digamos, plano elevada, granular, em algumas componentes até nodular, né? Talvez pensando no nodular mista. E aí, viemos para a conduta, né? Discutimos esse caso com todo o nosso serviço, não só da gastroclínica, quanto da coloprocto, o que fazemos para esse paciente de 30 anos que tinha essa lesão em reto distal. Tratamento endoscópico versus tratamento cirúrgico. Eu trouxe esse caso porque a gente optou, por incrível que pareça, por ISD, né? Então foi realizado em ISD em reto, por um dos maiores expertises em SD aqui no Brasil, um dos pioneiros, Dr. Nelson Miyajima, lá do ICESP. Então, ele estava nessa reunião da coloprocto e falou que topava a gente fazer, foi o nosso primeiro caso de SD num contexto de doença inflamatória intestinal. A ressecção foi completa, o histológico veio com um adenoma tubuloviloso com displasia de alto grau, atipia intensa, mas com margens livres. Esse paciente, obviamente, quando a gente pensou em tratar cirurgicamente, ele não quis fazer a cirurgia, era 30 anos, talvez a cirurgia nele seria uma colectomia total, né? E um paciente de 30 anos ia ficar com um anilho reto, enfim. Ele optou, né, como o próprio Rubin apresentou, ele optou em fazer o tratamento endoscópico e acompanhando, assumindo os devidos riscos. Isso aqui foi o nosso controle, foi uma colonoscopia de 3 meses, em que podemos encontrar 3 lesões, né, plano elevadas, mas lesões pequenas, que nesse exame de 3 meses nós ressecamos, 2 delas veio com adenoma de baixo grau e a outra como inflamatório. Tá? Repetimos a coluna em 6 meses, e realmente não teve mais recidiva de lesão, né? Você pode ver a retração circunferencial compatível com ISD, e como vocês podem ver nesse exame, nós biopsiamos essas áreas, mas não veio mais alterações, lesões residuais. Uma mensagem que eu sempre gosto de passar nesses casos: a gente tem que avaliar, tatuar a lesão. Aqui em reto, você não precisaria a princípio, mas sempre lembrar de tatuar a lesão, porque caso a ressecção endoscópica não venha, não tenha os critérios de cura endoscópica, vai ser um paciente candidato à cirurgia. E sempre biopsiar a mucosa adjacente para afastar lesões multifocais, displasia multifocal. Nós fizemos as biópsias, sim, após o ISD. Esse paciente perdeu o segmento porque em 2018 ele se mudou para o Japão, né? Mas continuou o acompanhamento, óbvio, lá no Japão. Ele já, eu entrei em contato com ele essa semana. Ele já fez 5 colonoscopias desde então. Infelizmente, eu não tenho as fotos. Eles, lá, como paciente, eles não têm acesso à foto. Mas, pelo que ele fala, paciente super orientado, que não precisou mais de nenhuma nova ressecção, de nenhuma nova ISD até o momento, né? Então, foram passados de 2017 para cá, passados 4 anos, ele vem em segmento. A gente sabe dos riscos de recidiva, mas ele está no Japão, então ele está bem acolhido aí contra a vigilância de câncer precoce. Obrigado.
Thank you, Alexandre. Dr. David, what do you think about this treatment, endoscopic treatment, ESD, or could be made a resection, mucosectomy?
Oh, first of all, I don't speak Portuguese, but I enjoyed the case and I was following along the best I could. And I do know Spanish, and of course that helps. But you heard me in my lecture say that I think endoscopic dissection is appropriate if somebody can do it. And this is an incredible example, if I'm understanding the case properly, that they did well, yes?
And do you think this lesion could be treated with ESR?
You know, it's hard. You know, first of all, it's a larger lesion that I would have considered for EMR, and the challenge there is that if you try to do EMR, you're going to end up with piecemeal in the best case scenario, and you may not be able to get such clean dissection of the subsequent lesion. So in this case, I mean, I think this is a compelling case. What I want to know is follow-up, right? So if somebody has a large spreading flat lesion and you remove it, good for you, good for the patient. But is this a phenotype of a lesion that tells us this patient in a year is going to have another big problem somewhere else? Or God forbid, it's going to be invasive the next time. So that's what I always worry about. And that's what we talk about, active surveillance. I think this person needs to be on a short interval for follow-up. But I hope I understood the case right. They did okay, yes?
Yes.
Okay, good.
5 years. 5 years for...
Fabulous. I mean, congratulations. Of course, that's always the case they present in a conference.
Yes.
Thank you so much. I have to defend a little bit. We choose this management because to have our first experience,
Yeah, well,
our service,
great experience.
An expertise center of IBD in São Paulo. Then you choose that. I tell everybody that I would be considered a criminal before 2015, before the scenic, if I choose this management on that period, But nowadays you presented some situations that we may consider ESD.
Right. So you know, and we didn't talk before I wrote my lecture, so you know I included it and said it was possible. How, just for the audience, how many cases did you need to do before you felt like you could do this, that you had competence? How did you get trained?
Yes, it's not me that performed this DSD. It's a colleague, Nelson Miyajima. He's a Japanese descendant, and he's on the pioneers, on the first expert endoscopy in this management in Brazil. Yes, We have seen in the literature, of course, ESD in IBD is more difficult than ESD in non-IBD, and it's necessary at least 200 ESD experience, in non-IBD for your practice in IBD patients. Yes, I don't have the experience of my colleague, but I think he has this number proper for perform this ESD.
And when you do these, I'm assuming it's under MAC, anesthesia support, right?
Yes, yes.
Propofol?
Tertiary hospital.
Yeah.
Right. And
yes, propofol.
do you use glucagon to stabilize the bowel so it's not contracting during the procedure?
No.
No. I think, Fabio, could I ask you something? Do you perform the biopsies and surrounding mucosa after the resection? That's your practice or not?
Hello, Chris. Thank you for inviting me for this very nice discussion. It's for me a pleasure to be in France. Thank you, David, for coming. It was such a very nice presentation. I was talking to Antonio Carlos in private. You could clarify everything that we have doubts about the timeline about the dysplasia over the years. So it was a very, very nice presentation. Thank
Yes,
you.
you're being very nice, Fabio, but I could be wrong about all of it.
No, you could.
As we say about my father-in-law, often wrong, never in doubt.
That's it. Chris, regarding your question, indeed, when you do a resection like Alexandre showed us, a very, very nice case, you must do some biopsy, random biopsy. That's it could be very, very useful for to have the idea. If you have a lot of positive biopsies, these patients must go for colectomy, because you can find a dysplasia in a random biopsy. This guy has to be underwent to a colectomy. I have just a question regarding this subject. How could we define very well if the lesion was removed completely? I understood that was very, very studied this specimen, but in a rectum, okay, you can survey you very well, but I never gonna do a case like this in other sites of the colon. Just the rectum, in my opinion, could be surveyed, like Rubin said, because in other places, like in cecum, even in the right or left column, could be very difficult to survey these patients. Could you discuss this a little bit more, Alexandre? If the lesion was in another site of the colon, would you guys perform the same resection? Alexandre?
For me or David Rubin?
Se fosse em outro lugar do cólon, você acha que seria...
Sorry. No, I heard.
Okay, go ahead.
My internet is stable. Then, of course, the easiest segment to perform this ESD is in recto. Yeah, it depends on the expertise of the endoscopist. Yes, but maybe nowadays it's only useful if we performing rectum. Yes. Tá me escutando?
Sim,
Yeah,
sim.
yeah.
Ele tinha cortado.
Sorry, é porque tinha travado. Sorry. Then rectum maybe is the easiest place segment to perform this ESD. And what about parameters? Of course, after scenic, if you have some parameters and the endoscopist has the expertise to resect these lesions, if he's capable of, he's authorized to do it. Yes, and the parameters are good, clear margins, defined, well defined. If you resect it, total lesion, and if the histologic parameters show us that the borders are free lesion, a free adenoma. Do you agree, David Ruby?
Yes, completely.
Yeah. Elisa, hi. Thank you for having been here. I would like to ask you if you think that the virtual chromoscopy is so good then as the same at virtual chromoscopy and panchromoscopy with indigo carmine or methylene blue. What do you think?
Yes. First of all, I would like to thank for the invitation. For me, it's an honor to be here with so important lectures. And I congratulate you, Cristina Flores, for the excellence of the course and Sobed also. I learned a lot. And about the question, I think is the virtual chromoscopy depends on the endoscopy. If you have training on virtual endoscopy, it's useful. Sometimes in the IBD, the mucus recover the mucosa, the lesion, and the dye endoscopy is very difficult because the mucus we cannot see in details the surface of the lesion, and it's necessary to wash a lot the surface of the lesion to see in details. And I'd like to Alexandre if did Nelson Miyajima perform a magnification on this lesion or only use chromoendoscopy?
He performed magnification when he did his ESD. Okay.
Oh, I see.
But I don't have the pictures.
Okay.
Great. Thank you. Antônio Carlos.
Morning.
Hi. Morning. Nice to
How are you in
have
the south?
here.
How are you in the south?
Yeah, it's a little bit cold here, but it's okay. I'm thinking here, if you, what do you think is the major reason for the cancer interval? Do you feel confident when you say to your patients to do a colonoscopy every 2 or 3 years, or you do another interval between the colonoscopies?
Okay. Thanks for your question. First of all, thank you for inviting me for this wonderful meet. It's fantastic to see David again. David, tomorrow's Mommy's Day here also. So
Okay, good. So you better clean the house after we're done.
I think I will have to clean the house also. You are not the only one. It's nice to be with Fabio, Elisa Baba. That's one of the most complete pathologists in endoscopy. She has the association between endoscopy and pathology, and these two fantastic rising stars that are Alexandre and Gustavo. So it's a fantastic table. Cristina, one of the main points is when you think about tight control, we also have to think about tailor control, if I can use this expression. And what we have to check is IBD duration, IBD severity, IBD extent, and one of the things that I cannot control is that genetic factors. Of course, if the patient has a history or primary family history of a rectal callow cancer, it's easier, but sometimes you don't know the family history. So it depends of the level of the lesion, of the kind of the patient. In this patient of Alexandre, for example, of course, I'm not waiting 1 year to have the follow-up, probably 3 months or 6 months after the resection. But what I think we have to have is a tailored direction in terms of follow-up.
I completely agree with you.
Eu concordo completamente com
Great.
você.
I think that we could go to the next case. Then we have some question in the chat, and I'm going to introduce this question after the next case, okay? Gustavo, please.
Ok? Gustavo, por favor.
Então, o caso que eu acabei escolhendo, ele vem a complementar um pouco o caso do Alexandre, parece que foi combinado, e acho que vem complementar de um certo aspecto também para a gente poder discutir talvez a parte histológica e se faria um segmento de repente diferente. Então, trata-se de uma paciente que ela veio referenciada, uma paciente de 46 anos, feminina, uma história de 7 anos com retocolite, tratando com infliximab, e o colega, na verdade, referenciou por ter visualizado uma história de uma lesão ali ao nível do reto. Então, a primeira histórico que a gente tinha de uma primeira colonoscopia é que o setup que ele tinha utilizado era uma EPK-1000 da Pentax e de uma lesão, viu uma lesão ali na região do reto médio e demais segmentos normais e foi tentado, então, uma ressecção com alça de polipectomia e fez uma biópsia seriada em conjunto com esse processo. Foi uma primeira colonoscopia, né? Então, ele já viu, já fez a dissecção. Então, essa descrição que a gente conseguia ver, pegando o laudo, né, e tentando mais informações, havia uma descrição da ressecção com alça, e na imagem as fotos não eram um arquivo muito grande, mas parecia um aspecto de lesão residual naquela imagem, onde seria a imagem pós-ressecção, né? Me ficou um pouco essa impressão. Na biópsia, uma displasia com baixo grau, um adenoma com displasia de baixo grau, e as informações no relatório do laudo da patologia nessa biópsia seriada, 6 fragmentos, 6 fragmentos ali de biópsia, sem alterações significativas. E aí, 2 meses após, também um aparelho EPK-1000, standard. Então, 6 meses após, foi realizada uma nova colonoscopia de segmento e novo diagnóstico dessa lesão na mesma localização, ficou até uma lesão recidivada, né, que seria o que foi conversado ali, embora provavelmente uma lesão residual. E foi realizada uma nova ressecção a psi-1000 e cauterização em cima com a alça de polipectomia. Na descrição com fotos, a mucosectomia psi-1000, cauterização com alça, mas também parecia em um dos pontos, não sei se de repente a foto não era a foto final, mas na foto que estava ali no laudo, parecia em um canto ali que existia alguma coisa visível. E mesma coisa, adenoma com displasia de baixo grau no anátomo patológico. Quando ela chegou no serviço, a gente conversou, então foi feita uma nova colonoscopia, setup diferente, né, uma Olympus 190 com o tubo 170, acho que o David nem conhece, né, só veio aqui pra gente no Brasil, né, gostaria muito de ter o 190, mas 170 já tá de bom tamanho. Aí a colonoscopia restante com aspecto normal, não foi realizada nenhuma biópsia seriada nesse momento, eu tinha um NBI ali à disposição para qualquer dúvida, aparelho de alta definição, e o aspecto de uma lesão que eu já vou mostrar à frente no lugar de descrever aqui para vocês. Então, essa é a mucosa colônica, uma mucosa bem bonita, né? Só para evidenciar, e essa era a lesão encontrada, né? Então, já dá para ver que era uma lesão mais espraiada, uma característica mais heterogênea, e áreas de importante fibrose ao redor da lesão, né? Na classificação ali que a gente olhava no padrão de criptas, chamava atenção num ponto central, só que a gente ficava um pouco de dúvida, mas bem disforme, né? Várias tentativas prévias de ressecção, cauterização. Aí fomos só para melhorar um pouco a imagem, fazer uma avaliação underwater. Aí aqui você vê que ela tem um ponto de friabilidade maior, que foi aquela história, né? Nunca jogar água em cima da lesão, né? Aqui, olha, vamos jogar água, seringa de 60, ó, joga devagar, ó que tá terminando de falar, o auxiliar já jogou, acabou pegando em cima da lesão e atrapalha realmente a visualização e uma avaliação mais minuciosa nessa área, mas a gente já tinha feito isso anteriormente. O NBI dessa lesão, tá? Uma visualização aqui melhor, depois de uma maior limpeza, onde dá para definir um pouco melhor ali os bordos, e com a cromoscopia com angiocarmia, uma definição mais interessante ali dos bordos da lesão, e aquele centro mais irregular, que parecia realmente que era um centro ali, que é um pouco semelhante àquelas imagens que eu via nas fotos anteriores da colonoscopia. A proposta de tratamento para essa paciente inicialmente era, na verdade, colocar ela num protocolo de estudos do robô endoscópico, que estava aberto o protocolo na época, para a gente tentar uma ressecção em plano total. Mas ela não se enquadrou nos critérios de inclusão desse protocolo de estudo. Então, nós propusemos a dissecção de submucosa para ela, já, claro, conversando sobre as dificuldades que eventualmente teríamos. Então, esse é o dia do procedimento. Então, a avaliação ali das bordas. E a minha preocupação inicial era a gente conseguir pelo menos um isolamento mesmo dessa área que a gente delimitava como bordas, né, para a gente conseguir ter uma segurança maior caso alguma coisa de repente desse errado na dissecção. Então a gente fez ali as marcações e realmente assim, eu não consegui elevar essa lesão praticamente em lugar nenhum. A fibrose era bem importante, não consegui que essa lesão elevasse para a gente trabalhar de maneira adequada. Mas eu fiquei visualmente confortável com as bordas. Então, foi feitas as marcações, ali a marcação lateral, o início da dissecção circunferencial, e aqui o aspecto de bordos que a gente conseguiu. Porém, para se fazer esse final dessa dissecção, foi necessária a utilização de uma segunda pinça de corpo estranho, então eu utilizei como se fosse um duplo canal, e acabou virando uma ressecção em 2 fragmentos. Tá? Acabou virando uma mucosectomia, procedimento híbrido, com uma mucosectomia psi-1000 no final desse procedimento. Esse é o aspecto final, foi feitas as biópsias dos bordos e a ablação com plasma de argônio nas margens laterais. Tá? E aqui o aspecto final após a ablação com plasma de argônio. No anátomo que veio de informação, era um adenoma com displasia, nesse caso, de alto grau. Até conversei com a patologista, eu sabia da dificuldade dela, da lesão ter sido fragmentada numa margem lateral, até falei para ela que eu estava mais preocupado nesse caso com a margem em profundidade, mas ela colocou que uma das laterais ela não podia garantir, então ela colocou como margem lateral comprometida, em uma das laterais, margem em profundidade livre, não quantificou em termos de percentual ou em micrômetros, mas colocou como uma margem em profundidade livre de neoplasia, sem nenhuma, não tinha infiltração ali em microvasos e em eixo neuronal, e as biópsias de bordas vieram como normal. E aqui a gente fez um segmento de 3 meses para avaliar a lesão residual, estava com aspecto cicatrizado, e essa é a colonoscopia de 6 meses. Também aqui a gente evidenciou essa área de cicatriz bonita, fiz as biópsias em cima dessa área que também vieram negativas.
Thank you, Gustavo. I would like to ask you, Dr. David, how much is common the multifocal dysplasia, and how sure we can do the resection of one lesion and the interval to follow up this patient?
Well, first of all, that was a beautiful case, and there's a couple of things I want to point out to the audience about that terrific case. Number one is that the patient was in deep remission. There's no inflammation. That's very important in doing all this, I think. Number two, I think it's so interesting and helpful. The 3-month follow-up, if I was following the Portuguese properly, the 3-month follow-up showed complete healing of the lesion. That time interval for healing is amazing. And I just want to throw out to everyone, why does it heal so beautifully, but the patient has chronic colitis that doesn't heal in other situations? Like, it's amazing, I think. It's so interesting. Okay, so I was admiring this, and I think it's important to know that 3-month follow-up is very important. Number three, I wanted to comment that sometimes people try to do EMR, or they inject the methylene blue or indigo carmine into the lesion, and that makes doing an ESD or subsequent removal much harder or not even possible. So it's very important that people understand that you shouldn't be injecting into the lesion if you're planning later to have somebody else try to remove it. So having said all that, in answer to your question, Chris, about multifocal dysplasia, it is important to know if there's multiple lesions that are present before you send somebody for this type of procedure, because you might be doing all this in one part of the colon, but the rest is not being addressed. And I know that in this case, it was addressed. I have a patient who just last week, I diagnosed a cancer in the descending colon. And the question was, could he have a local resection or even an endoscopic approach? But he, on his follow-up pathology, he had dysplasia in the rectum and dysplasia in the ascending colon, multifocal, and therefore he's going to have a proctocolectomy. So I think this is a key question. I can't tell you the number. I can't say that it's X% because I don't know. Maybe someone else can comment. Maybe Dr. Barrow could tell us, but I don't know.
Okay, thank you. We have a question here, and I can ask to Gustavo first, then the other colleagues could comment. Thinking that histological healing is important to get down the risk of dysplasia, maybe it's time for focus on the goal of histological healing to get down the risk of colorectal cancer and dysplasia, or is too soon?
We're walking in this way, in my opinion. I think it is important also to access the biopsies during the follow-up of the dysplasia also. For example, you can, after this procedure, maybe do some biopsies to look if you have also an histological remission and not just the endoscopic remission. But nowadays we have not all the concept about this type of remission, about the histological case.
Just for the reason to get down the risk of dysplasia, it's not the enough reason to pursuing this goal.
Well, I think that it's an admirable goal, and it's not that we don't know that histologic remission is a good thing. It is a good thing. What we don't know is how many biopsies do we need to get to show accurately that we have achieved it. We don't actually understand the timing of getting it. There are some newer studies, the phase 3 trials of JAK1 inhibitors are showing that histologic remission happens before endoscopic improvement, which is really interesting to think about. And we don't necessarily know what incremental changes in therapy get us to histologic remission. So, and then separately, of course, is training our pathologists so they know how to define it with us. So there's a lot of issues that remain, but I do think that moving in that direction is an appropriate thing to consider.
Thank you.
Please,
Yeah,
may I put a little bit of pepper in this discussion, because David is here. We are going to make like a food from Bahia, David. Bahia, we have a very, very, very spicy food.
That's fine. I'm hungry.
Yeah.
Oh, yeah.
So am I. So am I. I have some question regarding when you find several biopsies positive for dysplasia, even if it's a low-grade dysplasia. We have seen some data from Europe that the indications for procolectomy in ulcerative colitis, the problem of a remission is decreasing the number of intratability, and now we are seeing much more colectomy for dysplasia. So we are doing a better job, get our colons in remission. However, we are seeing much more dysplasia. So I think we are gonna have a very, very space for segmental resection, like David said, even in ulcerative colitis. We are thinking about that. When I graduated as a surgeon a couple years ago, I can say that would be like a sin to say that I'm gonna do a segmental resection for ulcerative colitis. However, nowadays I'm much more convinced that we can do that. So could you discuss this a little bit more, how you guys are doing in Chicago, David? Because I think we are facing a different scenario. Now we have very good drugs to kill the colon. However, we are going to find something else that in the past we never get. What do you think about that?
Well, I think it's a good conversation to have, and I'm grateful for the question. The first thing I want to say is that if we treat patients earlier to deep remission, what you're saying about finding more dysplasia later may not happen. But I agree that currently, as we're making a transition in the way we think about managing colitis, it's true that we're probably going to pick up more the better we are at this and the more patients who we follow long term. So yes. In the terms of how we do it in Chicago, I'll start by saying the first step to considering segmental resection in colitis was having a surgeon who was willing to do it.
Yes, that's it.
And I have 5 amazing surgeons. And in the early days when I was proposing this, only one of them would agree. So I worked with him. Now multiple will consider it, but you have to tell them what you want, and we work together. And it's a conversation. And I always tell the patient that ultimately the surgeon needs to help us know whether it's possible technically and whether it's possible medically, and we work together. The second thing I'll say is I think that this area needs to be further studied. And I want to emphasize again that the patient has to be in deep remission. Like taking out part of the colon and leaving an inflamed rectum or sigmoid is a mistake. And I think that if we make segmental resection a possibility, it has to be exactly like I suggested, in a patient who's in deep remission, in a patient who's willing and appropriate to follow up, and in a patient where the lesion is well defined and we know what we're doing. And those are high bars to cross, but they have to be met. Otherwise, you're just kicking the can down the road, delaying the inevitable. And in some cases, you're going to make patients have worse outcomes, as you know, I'm sure. But I'm very open to this, and maybe we can collaborate. Maybe Sao Paulo and Chicago can have a combined data set, and we can start thinking more about how to do this.
Yeah, totally agree.
Great. Thank you. We have a situation here. Can I share with you? Ellen asked, 46 years old male patient who had just the diagnosis of UC, pancolitis, only 4 months after the beginning of the symptoms, and was found 8 millimeters peduncular polyp at the transverse colon. Adenocarcinoma, okay, in situ in this polyp, and free margins. Usually this case would have a total colectomy. Does it evidence for avoiding surgery if he's go to histological remission and good surveillance program? What do you think?
So if I'm understanding the case, Chris, adenocarcinoma, but in what stage is it?
I think in situ, probably.
In situ, yeah, in situ.
Okay, I see. And the question is whether we would consider segmental.
If it's necessary to go to colectomy, or we can follow up this patient with a good surveillance program.
Why don't I ask my colleagues? We've heard some wonderful presentations here. Alexandra or Fabio or Gustavo, what would you guys do here? What do you recommend?
It depends on if there is a curative parameters. The histology, the deeper no invasion sought by the pathologist, yes. Not only the histology, adenocarcinoma, okay, but it's free margins, but how micro?
It's in situ and it's in situ and free margin.
All the criteria.
Yeah.
For me, it's if there is all the curative criteria, endoscopy curative parameters, it's okay. Only follow up. Do you agree, Dr. Elisa?
Yeah. But in this case, it's important also to remember that it's important to tattoo this area.
Of course.
It's not so easy to identify the scar after.
Perfect. I totally agree. I totally agree with my colleagues, but we must tattoo this lesion just in case.
May I ask a question to Dr. David?
Great, sure.
Thank you very much for your lecture. It's wonderful. And I would like to know about serrated idomas in IBD. We know that there is an increased risk in this patient.
Right. The sessile serrated lesions, we are interested in these, and we have seen this in a number of our patients. I try to distinguish between an isolated sessile serrated lesion and the patient with a sessile serrated polyposis, which can coexist with colitis, and maybe you've seen it. And we did combine our patients with Johns Hopkins and described that there probably is a risk of dysplasia in those same patients. The way I think of it now is that the inflammation risk may stimulate neoplasia down different pathways, and one of them is the sessile serrated pathway. So I think that this is likely maybe less frequent, probably less frequent, but it is a pathway that happens in some patients with chronic colitis. I have never needed to send someone to surgery for sessile serrated lesions. I've continued to follow them, even though my pathologist, John Hart, says treat this like dysplasia, I follow them. I remove what I find and I continue to follow. And I haven't seen anyone with progression. That's anecdote. So I don't know. What's your impression of it? What do you think, Elisa?
We have not so much IBD cases in my service. And I saw some lesion, serrated lesion. And I use frequently acetic acid to delineate the lesion, to see the details. I don't know your experience with acetic acid in this case.
I haven't used it. Yeah, I haven't used it, but I do look for the pit patterns, and I can sometimes tell it's a sessile serrated lesion while I'm doing the scope. And I always tell my fellow that I will buy them lunch if I'm right. And I've been buying a lot of lunches. But I think you can tell the pit pattern in a sessile serrated lesion looks like what you'd expect under the microscope. You see some sawtoothing and it's stars with ovals. It's a mixed pattern. It's very interesting to me.
Yeah, I agree.
Chris, I have a question.
Yes.
Dr. Rubin, this specific case presented from Gustavo is a good indication for underwater resection if non-IBD patient. Do you have any experience with underwater resection in IBD patients?
I haven't done underwater resections in IBD patients yet. Do you have the experience?
No, I don't.
Yeah, I haven't done it yet. It's an interesting question. Maybe we need to try. Has anyone done it on this panel?
No, for IBD.
I do a lot of underwater resection in cases, in flat cases, especially in this last case. I think we have a fibrotic area surrounding the lesion, and I think the underwater resection is safety in this case.
Great.
In fibrotic scar, I think is useful.
I'd like to comment only on important information. We know that non-lift sign is one of the criteria of non-resectable endoscopy resectable. Yeah, but in cases of IBD, non-lift sign is different of the original non-lift sign. Yeah, because of the fibrosis. Then, if you see a lesion, a non-lift sign, but you still know that it's resectable, endoscopy resectable, you may perform it. Yes.
A great point, Alexandre.
May I make a question?
Well, of course.
As we know, based on international data, incidence of colorectal cancer is decreasing all around the world, and I'm sure that is not a coincidence. We have endoscopic surveillance programs, we have better control of inflammation activity, but as we discussed before, we also had early colectomy in patients with dysplasia. Mm-hmm. Of course, so that I know that's a table with fantastic endoscopies, and endoscopies, they are killing the surgeons. But I would like to ask you about the future risk of cancer in this kind of procedure. Are you really convinced that we don't need anymore the early colectomy in these patients with dysplasia?
Well, I think like everything else, it needs to be individualized. I think that's the main message. And so if you go to my second to my last slide, the point or whatever it was, the point I made was if it's a patient with longstanding poorly controlled colitis and you finally got them under control, but it took a long time, that's probably someone who's got a high risk going forward, and you're going to be better off proceeding with a full colectomy in that patient. If it's somebody who has multifocal dysplasia, like we have to remember what our goal is here. The goal is to save lives and to prevent cancer death. And we can't lose track of that. It used to be that people died from ulcerative colitis. They died from cancer, and they died from hemorrhage and toxic colons. And, you know, it's like what I say, I have patients in my practice who we treated them aggressively for their Crohn's at the time of diagnosis, and they went into remission. They've never known what it was like to be really sick or to have multiple surgeries, which is good. On the other hand, they also don't have the fear of being really sick, and they're not necessarily as adherent to therapies. So we might get too relaxed about sending people to surgery if we keep saying, yeah, do another scope, take out just the right hemicolon. I think we have to be very careful, and we have to discuss the risks, and we have to think about the ethical issues about innovation. You know, when we say that it's possible, that doesn't mean that it's the right thing to do. And so I think what you bring up is a very important point, and that's why we need to study it properly and be talking like this. So thank you.
I'm bringing this issue, David, because as you asked, we are a huge country, and of course the experiences are completely different from center to another center. So
Sure.
I'm a little bit afraid of convince people that we can use endoscopic treatment for every center. We have to be very well prepared to be based on endoscopic treatment instead of surgical options. That was the reason that I brought this point.
Antonio, it's written that we authorize use if you are in expertise center of IBD, okay? Not any center. Yeah.
But as you know, unfortunately, some colleagues are not convinced about this point.
Yeah, it's complicated.
Okay. Our time is over, and I would like to thank you very much for all the colleagues, in special, of course, David Rubin, for your time and knowledge to bring us such great lecture. Antonio, Carlos, Fábio, Gustavo, Elisa, and how more can I said everyone. Okay. Thank you very much for your time. I have a great pleasure here. Thank you very much for all your participation.
Thank you very much.
Thank you. Thank you. Have a nice Saturday and a great
Mother's Day. David, don't forget to clean up the house, my friend.
Yeah.
And clean up the house, but not forget the gift. Huh?
Yeah, don't worry.
Yeah.
I don't forget, because if I forget, I will never be allowed to forget.
Okay.
Now
Thank you very much.
Thank you. Bye-bye.
Bye-bye.